Thanks all for coming. I'm Alex Leff. I'm one of the members of the CNR, and it's a great pleasure to have invited to have Katerina Hilari here from City St George's. She's a professor of acquired communication disorders there. Trained initially in psychology, amongst other things, and then went into speech and language therapy. Heavily involved in the CATS group, and some of the people in this room are as well. So the collaboration of aphasia trialists. So she's a trialist, but it's not just about language. She's also big on quality of life, which I imagine you'll be talking about, and headed up a group that came up with the sort of standardised measure of quality of life, the SAQOL, for stroke and aphasia, quality of life outcome measure, as well as many other things, and also into peer support and other things like that. So it's not just going to be about language and aphasia, it's going to be about other stuff as well, I think.
Absolutely. Yes.
So take it away.
Thank you. So, as Alex said, my background is in psychology. I'm a speech and language therapist, but my background is in psychology, so I'm delighted to be here to talk to you about supporting well-being. And I understand that we have an MDT audience, which is really what I was hoping we'll get, because this presentation is for everybody, it's not for speech and language therapy only. Well, it is relevant to speech and language therapists, but it's relevant to the whole team, I think. So what I'm going to do is I'm going to first talk a little bit about the background, so give you some context, what are the psychological consequences of stroke and aphasia, and what are the rehabilitation research priorities of people with aphasia, but also the priorities in terms of what outcomes they want to achieve in rehab. And then I'm going to sort of go over the role of all of us in supporting well-being, and think about what can we all do to promote well-being with people with aphasia that we work with. And I'm going to cover 4 different projects that we run at the moment at City St George's. The first 3 briefly, and focus a bit more on the last one, on PEeR-Befriending. Okay, so we all know that depression is very common after stroke. At any one time, about 1/3 of stroke survivors suffer from depression. And we also know that it is persistent. So 10 years later, 29% remain depressed. The prevalence of depression for people with aphasia is even higher. It's estimated to be between 45% and 70%. And people with aphasia 7.5 times more likely to have depression or depressive symptoms than those without aphasia after stroke. Anxiety is also very common. And we know from our own distress that social and emotional factors early post-stroke, so being depressed or having high emotional distress early post-stroke and feeling lonely or not being satisfied with the people you have around you, are the strongest predictors of depression later on after stroke. And of course, it's no surprise that high emotional distress is predictive of poor quality of life overall. And yet, despite this picture, which is very bleak, people with aphasia are often excluded from mental health interventions. We know from the literature that mental health professionals often find it difficult or impossible to work with people with aphasia, and they tend to avoid it. They feel you can't do talking therapies with somebody who can't talk, as one of them said in one of these studies. And we also know that they're excluded from trials. So from trials on psychological interventions after stroke, when you read them, I was reading all these full of interest to see what's happening and looking at the people with aphasia that I work with, what happens. And in a lot of them, people with aphasia are excluded because it's assumed they can't do the measures that they use, the outcome measures on depression. If we look at the priorities of people with stroke and aphasia, I'm sure all of you will be familiar with the stroke priority setting partnerships between the Stroke Association and the James Lind Alliance, where they consulted with a lot of people with stroke and their families and health professionals to establish priorities for research in stroke care. And in terms of rehabilitation priorities, the top priority was addressing the psychological consequences of stroke. And there is an international study that involved people with aphasia, specifically people with aphasia from many countries, different countries, And they looked at what rehabilitation outcomes are most important to them. And of course, as all these people had aphasia, outcomes in relation to communication and participation were top. But again, we see that addressing emotional well-being was in the top 5 priorities. So bringing all this together, assessing well-being and addressing well-being is a priority for people with aphasia. And depression matters, not only because people don't feel well, but because depression affects rehab. It affects the work that we all do. It affects the gains that people can make through rehab, the long-term outcome they can achieve, and it even leads to higher mortality rates. And we also know that depression is persistent. So not only do we need interventions to address depression, we also need interventions to prevent it from occurring in the first place. So interventions to promote adjustment and well-being and hopefully prevent depression. So what is our role in all this? I mean, obviously, for people who have depression, you expect that a psychologist, a counselor, a psychiatrist may be involved depending on the severity of the case. But what is the role of the rest of us? What can we all do about it? Well, if we look at the National Clinical Guideline for Stroke, which is supposed to tell us what we should be doing in practice, it says that services for people with stroke should offer psychological support to all patients, regardless of whether they exhibit mental health or other cognitive difficulties. And all members of the stroke multidisciplinary team should be trained and engaged in supporting the well-being and psychological problems following stroke. So I'm going to talk very briefly about the stepped care model, and I know this is a very busy slide, which I see also hasn't come through very clearly, but I'm just going to highlight the main points. So the stepped care model of psychological care was conceptualized to sort of facilitate and make access to psychological care easier in constrained, in settings where there are resource constraints. And the National Clinical Guideline advocates a matched care model, which is slightly different, but these models are not in opposition with each other, so it does work within a matched care model. So the idea is that, the pyramid sort of represents, the patients and the problems they may have. So at the bottom, for the majority of the stroke patients, you have those that would have sub-threshold problems, so they don't necessarily have depression or a substantial mood problem, but they may have low mood, they may find it difficult to cope. And at that level, the idea is that support is provided by peers and stroke specialist staff. So we are meant to support these people. At the next level, we have people who have mild or moderate problems of mood. And the idea here is that, again, they can be supported by stroke specialist staff under supervision of a clinical psychologist or neuropsychologist. And that leaves the clinical psychologist and psychiatrist to deal with the more persistent and severe cases. So this is the model within which we are meant to operate. So from what I'm talking about from now on, I'm focusing on level 1 and a little bit on level 2 interventions, which are the ones that all of us are supposed to be offering. Okay, so how can we support people with aphasia and their emotional well-being? And first, I'd like to go over what people with aphasia and the family members told us themselves. So I'm going to talk to you a little bit about the REA study. You see here what it stands for, which is led by my colleague Sarah Northcott at City St. George's. And this study actually stemmed from something else. So we got funding to develop training, specialist training on supporting well-being for healthcare professionals working in stroke. And when we started working with people with aphasia to co-produce videos and stuff, they told us, actually, we'd like to do something slightly different. So we'd like to say what we think people should be doing. We'd like to talk about what supports our emotional well-being and what damages our emotional well-being. And so we'd like to raise awareness more broadly. So it would be nice to make videos that we can make them freely accessible and people can watch them and become a little more aware of what we think and what may help. So this is what we did, and we produced 4 videos. So the videos are available on our City Access website, which is the website where we share all the outputs of our research at City St. George's. and we created 4 videos. So the first is this one, and the last one are sort of people's stories. John's story is the shortest one. He had a very severe aphasia, but now he was able, years ago, now he was able to sort of say his story and what he thought. And it's about having, his stroke over Christmas and how he is now. But the first video, Joe that you see on the screen there and Michael talk about their aphasia journey. And then the third video is a family member talking about their experience. And the one I'm going to focus on a little bit more is this video. This is our longest video. It's 18 minutes, and it can be used in training, for example, training students, health professionals who work in stroke, or training our teams, our colleagues, a little bit about, what people with aphasia told us. So I'd like to show you a clip of this video, and I'm going to move on to show you the video, but for those, I know this is recorded, so if people are watching this online, please, this is not going to be in the recording, so please follow the QR code and choose this video and watch from 7:30 minutes for about 6 minutes. The next video that I didn't, the next clip is somebody who was a very intelligent lady. She didn't want to be seen, so it's Sarah sort of telling her story on the video. And she was talking about, she spoke 6 languages before she had her stroke. She was an interpreter, and nobody was talking to her. So she felt that she wasn't treated like a human being. Everybody was talking over her. And then there was a healthcare assistant that was bringing her coffee and tea. And at some point he talked to himself and he spoke in Spanish. So she understood what he said. And they had this, he was so happy that she understood. And from then on, he always would spend a couple of minutes with her. And this connection made such a difference that she remembered this years later, and she sort of said how important it was that this person connected with her as a human being. So these are the main things that people brought up in terms of what damages well-being. And then these are the things they told us support well-being, and a lot of them are about good communication. So listening with empathy, trying to be kind and treat people as people, which is sort of, we think, of course you do that, but why doesn't it come across for people who are in hospital? So something is not quite working there. And I don't think it's anything that would take too long or anything. It's just about looking at people, asking them, saying hello, saying how are you. You may not understand what they're trying to say, but that's okay. It's okay to acknowledge this, but trying to support communication and treat people as human beings. Okay, so what can we do? I think it's important to acknowledge that a lot of healthcare professionals don't have training to support communication, and this is a problem. And we need to build skills to help people communicate better with people with aphasia. So this is what we're doing with the ComStar project. This project is a project that is looking at changing the way stroke survivors with communication difficulties, so this is not just people with aphasia, it's all different communication difficulties are included in their care and rehabilitation. So the project aims to understand what's happening currently, what is the communication context in hospitals, what training people have had, and then design training that will be sort of implementable in the NHS setting. So this is the team. It's a very big team. It's led by Rebecca Palmer from Sheffield and Madeline Cruz at City. And the team includes different stroke professionals, people working in universities and clinical practice. We have international partners from Australia and Denmark. And we are very lucky to have in the team Professor Chris McKevitt, who leads the PPI, and he's a stroke researcher, a widely published stroke researcher who then had a stroke and now has aphasia. So the first year of the project looked at understanding the context of communication and what communication training people have had, people who work in stroke care. So this is not just professionals, it's everybody who works in stroke care. So we run systematic reviews, quite extensive systematic reviews to see what's out there in terms of training. We ran a survey which has now been completed, and I think it's probably the largest survey of stroke care staff in the UK. We had over 600 participants across different disciplines, mostly allied health professionals, but we did manage to get healthcare assistants and other people working in stroke care. And we also ran interviews. The survey covered, what's happening at the moment, what training they've had, what they would like to see in training, what are their needs, what do they feel they're doing well, what sort of they don't feel confident about, all sort of related areas. We also did interviews with stroke care staff and people with aphasia and family members. And I'd just like to show you a couple of comments that stroke care staff made in the interviews, and we've had consent to share this and people's pictures and names. So this OT said, in terms of communicating with a person with aphasia, or I think this was for aphasia, it's terrifying because you don't want to get it wrong. A stroke consultant told us there's no training for such things, no sign-off. A housekeeper was saying having more strategies and resources would make staff feel confident and that they were genuinely putting the patient's needs and preferences first. And this person actually was somebody who, when we asked her what she does, she had so many strategies, so many lovely strategies she was using. And she says, I picked it up, going and seeing what the speech therapist does or seeing what other people do. I picked up so many things, and she was using so many strategies. And then I really value this comment by this dietitian who said, there's a fear because I'm later on in my career, so I should know how to communicate, but I can't. It's uncomfortable. And I think this may resonate with other people as well, because it is uncomfortable and it is difficult when you're trying to talk with somebody and you don't understand what they're trying to say and you don't know what to do. It is difficult. So we're now in the second year of the project that we're taking all these sources of information together, and we are co-designing with people with communication problems, family members, and stroke professionals a training package. And then the training package that will be developed will be tested in 4 sites, 2 in London, 1 in Sheffield, and another one in, I think, Doncaster and that area. And we will see what happens in practice and how it works. Do actually people do it? Can all people do it that need to do it? Do they change anything in practice? So that we're looking at whether there will be an interactive element. And then, we will refine the training, and it will be made widely available and freely available. And the QR code here is for the website of the project. Even if you Google ComStar stroke, the project website comes up, and videos of what people have told us so far, healthcare staff and people with communication problems, will be on the website very soon, actually. Okay, so I've talked about raising awareness, I've talked about simple things we can do, talked about communication training and what we should be doing there. And now I'd like to cover some interventions that have been used with people with aphasia and services as well. So in the long term, what's commonly available, and I think we're all familiar with, is the community groups that there are. And in the UK, we have multiple groups run by the Stroke Association and aphasia-specific charities. Say Aphasia has resources as well for people who want to set up groups in their community. But for those interested, or if anybody's trying to sort of develop some activity in the community in terms of building groups, there is a lot of work from the Aphasia Centre for Research Excellence in Australia, where they've actually run studies. The 2 names you see here in the references have done their PhDs in the area, and they have created a lot of resources that they make freely available to support people setting up groups. In terms of specific interventions, a lot of interventions have been trialled in stroke, a lot of psychological interventions, less in aphasia. So I'm going to look at some that have randomized controlled trial level evidence in the UK and have included people with aphasia. So the best level evidence we have is for the CALM study, behavior activation therapy that Shirley Thomas ran from Nottingham. And the therapy here is getting people to do more activities that help them link with more people. And this contact with people and doing activities create positive reinforcement and actually gets them to feel better. It's a level 2 intervention, and it's delivered by assistant psychologists. Acceptance and commitment therapy is another therapy that is very early on. There's just been a feasibility study on this by Emma Patchwood, and it's delivered in groups and online due to the pandemic, the testing here in the UK. But it's a promising thing for the future, I think, but we don't have much evidence still at the moment. Both this therapy and solution-focused brief therapy are delivered by stroke professionals under the supervision of clinical psychologists. So solution-focused brief therapy was trialled in the feasibility study led by Sarah Northcott at City, the Sophia trial, and it had very good outcomes. And the last one is the Superb trial, where we tried PEeR-Befriending. So I'm going to talk about the last two a little bit more. So the Sophia trial had very positive outcomes in terms of, being able to do actually a psychological intervention with people with aphasia and them reporting the benefits to themselves and also changes in clinical outcomes. So under the leadership of Sarah, we applied for more funding to develop a new service and test the feasibility of a service for people with aphasia in the community. So this is the WISER study, which is currently undergoing. It's not yet completed, and it aims to support well-being for people with aphasia and their families, offering solution-focused brief therapy. It's a before and after study, and the target is to get 30 people. And this is the team. So the most important people are the two last pictures. It's Sarah and Nikki Atkins. So they're the research therapists. They're delivering the intervention under the supervision of Joe Eden, who is in the middle picture. So we've recruited to target, which is lovely. The people who took part, we had more women than men. And they were slightly younger than they were younger than your average stroke survivor, but they were of a very wide age range, from 34 to 80. And also almost a quarter had severe aphasia, which is really lovely to see, because these are the people that are typically excluded. The majority were white, but we did have other ethnic backgrounds, and they came from London and outside London as well. And in terms of how they accessed the service, a third came to the clinic. So they came and they had face-to-face therapy in the clinic. Half accessed the therapy online, and 5 persons had both. They came to the clinic and they had online sessions, so they had a hybrid model. And the majority had one-to-one therapy. 3 people attended with a family member together. And then we were interested in the feasibility of doing this therapy in groups. We had 3 people forming a small group. It was good to see that there were more people that were interested, but for logistics, it wouldn't work out in terms of when the therapy could be offered and having other people who were interested in a group. So we ran one small group. And in terms of the findings, in terms of recruitment and retention, the findings were very positive. We managed to recruit to time and on target. People came mostly from the community, community groups, people that were known to us, word of mouth. And we had very few people dropping out in any way. Once they started the therapy, they completed the therapy, so far at least. In terms of the clinical outcomes, and as I said, these are interim findings. We haven't finished with everybody. There are so far positive changes on well-being and a reduction of emotional distress, so positive findings. Of course, the funding has run out, so we can't offer the service at the moment. We're not recruiting anymore, but we have applied for further funding and gone to the second stage, so we're quite hopeful we may be able to continue offering this service here in London. So coming on to the PEeR-Befriending intervention, PEeR-Befriending is a level 1 intervention, so it's for people with sub-threshold mood problems, and we trialled it out in the Superb trial, which was led by speech and language therapists and delivered by people with aphasia. Superb trial was a feasibility trial. This is the team, and these are the researchers that ran the study. And I would also like to thank specifically the different people with aphasia that sort of contributed to our study. The consultants with aphasia were people who had experience of peer befriending from before, and we talked to them even before we applied for funding. So they really influenced what we did and how we did it, from conception to, sharing the findings and dissemination every step of the way. We also had an advisory, a user group that advised during the trial, and of course the people who delivered the intervention, the befrienders. You see some of them here with the supervisor, Sally McVicker from Aphasia Reconnect. Okay, so our findings are published, they're on our website, and we have, as well as our papers and general information, videos of our findings that can be shared with people with aphasia as well. So what is peer befriending? It's emotional and social support provided by people who have lived experience of a condition to others with similar problems. And through this lived experience, the befrienders can offer genuine empathy and hope for the future, as well as advice and ideas about how to cope. And there is evidence from systematic review and meta-analysis on the effectiveness of befriending, specifically in terms of reducing depressive symptoms in various disorders, not in stroke specifically. In neurological conditions, there's a more recent meta-analysis that reports positive outcomes in health, confidence, and self-management. Why did we choose peer befriending? So we chose peer befriending because it capitalizes on the skills of people with aphasia, and we thought that's really important. They are the agents of change, and you can, hopefully have benefits, not just for the people receiving the intervention, but for the people offering the intervention as well. A peer befriending scheme is something that can be, in your toolkit of resources. It can be a package that you can run alongside different services, and it can be available to people with not much cost at all. It's particularly useful for people who may not be ready to get out of the house, so people a little earlier in the stroke and aphasia journey. And befrienders visiting at home can help people actually feel more confident and get out there and start getting support from more widely available services. Okay, so what did we do? So we aimed to recruit 60 people, 30 randomized the usual care, whatever that was in where they came from, and 30 usual care plus peer befriending. We also recruited 10 befrienders, and these are people that were recommended to us from the services we worked with and from community groups. So we were asking for people that had adjusted well to life with aphasia, that wouldn't fatigue, so they were able to go for 2-3 hours without really getting very tired, and they were able to travel independently, so they could go and visit people at home. And also they needed to be people who wanted to give something back, who wanted to help other people with aphasia. So we trained the befrienders. The training was 5 to 6 hours, and we broke this up to 2 to 3 days, so people had sort of this time to process what they were learning and revisit things. And the training is fully manualized, and also the befrienders get a handbook for the intervention, so they have a handbook with resources that they can use while they're out there offering the intervention. And then they had regular monthly group supervision sessions, and as and when needed, individual supervision. One thing we did in our study is we matched the befriender and the befriendee. And this may seem very common sense, but it's not necessarily the done thing. So with peer befriending, or peer workers as they're called in mental health, for example, that they're very, very established and widely used, they don't necessarily match them. Whoever is available goes. Actually, we made some effort to match people, and I think this actually made a difference in our outcomes and everything, because I do think it is important. So in terms of matching, the most important considerations were logistics, so geography. They needed to be able to go and visit the person. Also practical considerations, like were they smokers, did they have pets, were there any issues with that? But we asked people, as you see, about interests and hobbies, whether they had any preferences in terms of culture or ethnic background, any preference in terms of the gender of the person visiting. And we took as much of this as we could into account with the matching. We took into account whatever was important to the people. So the scheme was 6 visits over a period of 4 months. with the option of having a further 2 visits in the following 6 months. So you make the transition from having somebody visiting regularly to nothing more smooth. And the scheme kicked in at a time that we thought was of high need. So people were at home in the community, but it was after they finished with early supported discharge, for example. Or if they were in a community rehab setting, after, when they were being discharged, they stopped having regular therapies. Because this is the point that people say, okay, I'm still aphasic, and clearly I'm going to continue being aphasic in the long term, and yet everybody's going. So it's a time that people sort of needed some support. So befrienders would start visiting at that stage. The first couple of visits, it was really important to establish a rapport, because this is a key ingredient of this intervention. There has to be a relationship that is mutually supportive. And then they would talk about practicalities, the frequency, and what they would do in the visits, and maybe decide what they wanted to do. And subsequent visits included, as you see, conversation, problem solving and advice. And for some people, trips like to a local group or to a coffee shop. In terms of feasibility outcomes, we looked at typical things that people look at when you want to see if it's feasible to do a study. So can you recruit? Is your recruitment rate good to recruit on target? Do people consent once they're eligible? How many people withdraw? And we also looked at acceptability outcomes. Do people complete the study and all the outcome measures that we were using? Do they complete the intervention as intended? And we collected qualitative interview data to add depth to these numbers. So we collected clinical outcomes at 4 months, which was at the end of the intervention for those having befriending, and then 6 months later with no specific intervention or follow-up at 10 months. These are the measures, the outcomes that we looked at, and the measures that we used was the General Health Questionnaire for Depression, the Warwick and Edinburgh Mental Wellbeing Scale for Wellbeing, the Community Participation Item Bank, the Community Integration Questionnaire, and the last 2 measures were sort of exploratory measures for us. We weren't sure whether we should be expecting changes here, but we looked at the Friendship Scale and the Communication Confidence Rating Scale for aphasia. Okay, so these are our participant characteristics. Again, busy slide. The only thing I want to highlight is that our 2 groups were very well matched in terms of age and proportions of people who had physical disabilities, male, female. And what was really important to us was that a quarter of the people in each group had severe aphasia. So again, we managed to get people with severe aphasia to have this intervention. So I'm using a traffic light system to indicate whether the outcomes are good or not so good, and color coding. So generally feasibility was very good. Anybody who's been involved in a trial will know that your recruitment rate is very different to what you plan, and it's always slower, but we managed to recruit to target by increasing the sites that we were working with, extending the period a little bit, and working very hard with our recruiting sites. The study processes were acceptable to the participants. The participants were able to complete the outcome measures, and they really liked the researchers giving them time and doing the assessments in a very considerate manner. And the peer befrienders found the processes acceptable. So I'm highlighting this paper, which is the fidelity of the intervention, because I think it gives more information on the nitty-gritty aspects of the intervention, on the matching, on how many were matched with what criteria. We have in this paper, in the supplement, our fidelity checklist, so we can see actually what are you expecting to see in the interventions, what is actually happening when the 2 people are talking. So we looked at the fidelity of the intervention. In terms of compliance to start with, over 80% did all the visits, and over 90% completed at least 2 visits. All the befrienders completed training as intended and supervision. So then we looked at adherence. So actually, did they do things as we would expect them to do? And what we did is we filmed all the training sessions, all the supervision sessions except the first and the last one, because the first they were getting to know each other, and the last one was a party, basically. And then 1 visit per pair out of the 6. And we, independent raters, looked at these videos against the fidelity checklist and rated whether things were happening that we wanted them to happen. So adherence was excellent for the training and the supervision, and high for the befriending visits. So here, as you see, the range is wider, but it was only 1 out of the 20 visits that we looked at that was below 80% adherence. So coming on to the clinical outcomes. So this is probably the most interesting thing, but we need to bear in mind this is a feasibility trial, so it wasn't powered for to detect effectiveness. Very busy slide, but color-coded to help. So this slide shows the differences between the two arms, the intervention and the control arm at 4 months, and the differences at 10 months. So in some measures, there isn't really much difference at all. In a measure, people go in the opposite direction than what we would expect. You know, those in the control arm seem to be doing better. And then in the ones that are highlighted green, the intervention arm is doing better. If we look at the primary outcome measure, which is the key measure we were interested in, the GHQ-12 is a measure of distress. So it goes from 0 to 12, and the higher the score, the higher your distress. So low scores are good scores in this measure. And in the general population, there's a cutoff of 2. So if you score between 0 and 2, it's considered that your mood is fine, absolutely fine. If you score more than that, in stroke we use over 3, you may have depression. There needs to be a discussion. You may need to see your GP or somebody specialist to address the depression. So at baseline, both groups, the befriending one is in green. Both groups at baseline, the average scored, on average, they were scoring on the depressed range of the GHQ. It was lower at 4 months and lower at 10 months. So, and both groups were within the normal range of the measure. If we look now at sort of the categorical data, so if we split them as like depressed, non-depressed, although this is not right, it's those that display depressive symptoms versus those that don't, because they haven't been assessed by a psychiatrist. So if we look at that, at baseline, 57 in the usual care arm scored in the depressed range and 54 in the PEER arm. After 4 months, both had improved. So 40% in the usual care arm, the PEER arm had gone down to 30%. And at 10 months, the usual care arm remained at 40%. So here we see the picture from the literature that depression, once it occurs, it's persistent. It's exactly this image. So between 4 months that people sort of had just come out of active rehab to 10 months, exactly the same, whereas in the PEER arm, people went down to 11%. So this is a very marked difference to the extent that our statisticians would not share the findings with us. They kept asking us and checking whether there were any errors in the data, because it is a marked difference, that it represents an 88% decrease in the odds of caseness on the GHQ. But it is a feasibility study and it's a small sample, and we put a lot of work in this. We did things as best as we could. So obviously, we can't have the confidence that you would have in a definitive trial, but very positive image sort of emerging. We also looked at what people told us in qualitative interviews, and it's important to see whether what we get in the qualitative interviews matches the quantitative data. So the befrienders told us that there were many positive aspects. They liked the training. They liked revisiting topics of the training in the group supervision, and they appreciated the peer support they got in the group supervision. And they also thought it was really useful to have the option to have one-to-one supervision when they had difficulties, when they had problems. They talked about the visits, and they said they shared stroke stories, they chatted, they went out, so they enjoyed all that. Having severe aphasia didn't prevent close bonds from developing, and humor and having a common shared experience facilitated these bonds. And the befrienders felt that the relationship was two-way and reciprocal as well, so they didn't feel that they're helping others and that's it. They felt it's a reciprocal relationship. And that's a quote that sort of reflects this. I love it because also it benefits me. It's a bit of a challenge. Open the door and see who it is. I know I've got someone behind me. I feel secure in that way. So this befriender here talks about the reciprocal nature of the relationship, but also the benefits of supervision. There were also challenges. The challenges were mostly logistics. So, finding your way, making your way, the anxiety of getting there and getting in time. Sort of these things were challenging for the befrienders, but they found the support of the team, of the research team, useful there. And also, witnessing the person they were visiting distress. So they were visiting people that were earlier after stroke. They remembered things they had gone through. They saw some struggles, and emotionally this was difficult for them. The other thing that was difficult is if they felt that the person they were visiting wasn't really engaging as much as they were hoping. So like they would go and the TV were blasting in the background and wouldn't be put down. There were other people in the room chatting away, things were happening. So, or, you know, somebody would cancel a visit again and again. So that was hard. Overall, though, they found the experience of offering befriending interesting and rewarding. They saw it as a secure challenge that helped them reconnect with the pre-stroke self. Many talked about likened it to having an employment again. And they also said they did more activities, which wasn't something we necessarily anticipated. They talked about the speech getting better, which, again, it wasn't something anybody worked on, but maybe the activity and doing something important helped that. And overall, they talked about a renewed appreciation about who they are and what they can do. And they said that they would recommend befriending be implemented in routine care, so it's available to people with aphasia. Looking at what those receiving the visits told us, they told us what they valued in the befrienders. So they thought they needed to be people who are chatty, sympathetic, and patient. And from their perspective, the visits planning things was not a problem. They saw their befrienders as inspiration for future recovery. They really valued their lived experience, and they thought they were role models for them to look up to and learn from. And they also felt that their relationship was reciprocal, and they were getting something out of the visit, and they really benefited from the advice they had. They unanimously agreed that they would recommend befriending to other people with aphasia, and they highlighted the benefits to their emotional well-being. And as one of them said, they are experts. They have been through the same path, so they are the best people to talk to. It gives you the confidence and hope that people have been through it, that you can also go through it and be perfect. It's not the end of life. So we think with all the things that we heard and we saw that, peer befriending is a unique form of support that helps those early in the stroke journey begin to make sense of what's happened to them, of their aphasia here, and begin living well with aphasia. And for the befrienders offering the intervention, it helped them feel that they're making a difference, that they're doing something useful and they're helping others. Okay, so summarizing what we found in our trial, peer befriending is a scheme that can be delivered by people with aphasia with high fidelity, with supervision and support, obviously. Our outcomes are very positive, so preliminary evidence of benefit on the clinical outcomes, and overwhelmingly both parties felt it was valuable and helpful. So it's something that can be a useful add-on to service provision. So we have developed training for how to set up a peer befriending scheme. And this is online. It goes over 8 weeks, but it's completely self-directed. And, we train stroke healthcare professionals on how to set up a peer befriending schemes, and they get all our manuals and the intervention workbook to share with other people with aphasia. So if people are interested, you can sort of say that you're interested. We haven't determined when the next round will be. In terms of final thoughts, bringing this to a close, I think stroke professionals need training and support to improve their communication with people with aphasia, but also to develop skills on specific interventions that promote well-being. Even sort of learning how to do mood screening tests, but also there are various techniques that have been tested and we can use with people with aphasia as part of our interventions. For those that are speech and language therapists, there are interventions that combine psychological techniques with speech and language therapy. So while you're doing aphasia therapy, you are using psychological techniques. So we've got a grant at City that looks at combining solution-focused brief therapy with, so far we've tested it with semantic features analysis in people with aphasia. And I know in the States there is a similar study that looks at acceptance and commitment therapy together with language therapy. But I think the most important thing is that we need an integrated and flexible service provision that continues in the long term, and people have choices, because not everything is suitable for everybody. With any behavioral therapy, the person has to to think that this is going to suit me. We talked about some of these here. There are other approaches as well that would be useful to have available. Okay, so that's it, and that's the City Access website that I mentioned, and our team here at City. So just to show you who we are, and all the outputs and links to our projects are on our website. Thank you.
That was great. Okay, we've got before wine and crisps, we've got time for a few questions. I might get the mics out so everyone can hear.
Much, and clearly a really important body of work and a lovely talk. I was wondering on Superb trial. You know, on your depression scale, they were at the low end, sort of 3 being the highest out of your 12-point scale. And I maybe wonder whether there's an kind of we always have a bias in our recruitment in that who volunteers for trials is, you know, not always typical. But do you think there's a particular bias when you're doing well-being studies? Because if you're very depressed and apathetic, they go together. You know, you're never going to get into those folk who are actually getting into level 2 and maybe heading towards level 3 needs.
So that's a very good question, and the two things I think which are relevant for our study. So the first thing is that the measure is very skewed. So it's not, the GHQ does not have a normal distribution because it's a screening tool for distress. So the majority of the population scores between 0 and 2 in the general population. So this is, if you score 3, it's actually high, and 4, you know, it's not nothing. But also our intervention was for people with sub-threshold problems. So we couldn't have people who had depression because this is not the right therapy. And there is a danger that if people knew that they were taking part in a trial for well-being, they wouldn't have access to the actual usual care that they would need. So, you know, if they had depression, they probably needed medication, they needed more psychological support than what we offered. So we wanted the people who had lower well-being. Having said that, in the SOPHIA trial that was looking for people who were distressed, if we split the people between those that had low well-being at the beginning versus those that had high well-being, those that had high well-being didn't improve as much. Those that had low well-being obviously improved. So that shows that it is a level 2 interventions for people who do have problems. Yeah, thanks.
Thank you. Any other questions? Just with the Superb trial, I just wanted to check if I got it right. So there was the baseline, then 4 months was when you'd finished the intervention,
Yes.
is that right? And then your big, really nice finding, which the statisticians wanted to hide from you. We all love statisticians. I mean, we've seen this with the upper limb service and to some extent with the ICAP service that we ran, although neither of those were randomised controlled trials, that benefits seem to happen or sometimes get more significant even when it's finished. So
Yes.
there's this lag.
Yeah.
Which seems a bit counterintuitive, because like if it was a drug trial, when people stop the drug, you'd expect them to go back to where they were. So have you got any thoughts on why it was at 10 months and not at 4 months?
So I that's a really good question. I think for certain things, I would expect the biggest change to be just after the intervention, because that's like in aphasia therapy, in language, probably you expect the bigger change to be just after the intervention. Then people start, there's a slight drop. But I think with things like how you feel, and we saw this with quality of life outcomes as well in other studies, there is a lag. So people actually improve after, not immediately after therapy, because it's still a lot going on. And generally, our well-being and our quality of life are quite stable constructs. They don't change. I mean, we all go through more hard situations, more difficulties. You wouldn't say, oh, my quality of life is really poor today. It doesn't go like this. A lot needs to happen for your overall well-being and quality of life to change. So I think they're more resistant to change, and that's why the change shows afterwards. It's cumulative, and actually they're saying, do you know what? I'm actually much better now. I think it shows later. Yeah.
I mean, the PEeR-Befriending thing seems very powerful, actually, and I don't know how much we do it in stroke. Do we do it in the upper limb? Do you do PEeR-Befriending? Or sorry, it's a question for the audience.
No, I was just thinking about the upper limb programme, for example, where they come in from 9 till 4 for intensive rehab. But when we did some qualitative data with the groups, they really benefit from the peer support. That was one of the highest things that came out of the qualitative data. But I think the befriending stuff has started in NCL, which is North Central London, where there's about 4 rehab assistants that have started to do some befriending work through stroke and supporting people through getting out and about, carers cafe, that kind of stuff.
Mm-hmm.
And I think it's hugely beneficial for those patients.
Yeah.
A question I did have for you was, you had about 6 visits, is that right? Over.
Yes.
Did they stay for? Actually, I knew one of the ladies on there. She's been on the uplink programme. Did they stay for 1 hour, or did you kind of?
It was about 1 hour. So the average was about 1 hour, a little less. I mean, it was meant to be 1 hour, but some of them were slightly shorter, maybe 45 minutes, 40 minutes. But I think the median was 50 plus minutes, so close to an hour. Yeah.
Yeah, it's really powerful. Your results on kind of long-term benefits at 6 months.
We weren't expecting it. As I said, it was a feasibility trial, and we're just hoping that, we would be able to do it, that in qualitative data we would get positive outcomes, which we knew we were probably going to get. But we weren't expecting such changing in clinical outcomes. And as I said, some of our assessments were very, let's throw this in there and see what happens, because it was a feasibility. I mean, we knew that GHQ was the main outcome. Others, we were not certain what to expect.
And did they become a little bit dependent? So one of our peer support issues we have on the Upper Limb programme is they all share WhatsApp groups.
Yeah.
And then they carry on supporting each other. So I don't know whether that happens. Is there kind of boundaries within the
So we had discussions about this, because some befrienders came from Aphasia Reconnect, where there's no ending to the befriending. People can sort of, they become friends and then they see each other for years. But we said it needs to be with boundaries, and it needs to finish, because if we want to see this in a service provision in the NHS, you can't expect people to be visiting people for years. It's really to get them out there so they can connect with their friends, they can make new friends, they can go out in the community and do what they need. So the befrienders found it a little hard, and also they felt they didn't manage endings very well, whereas it wasn't a problem for those receiving, for the majority of those receiving the intervention, but it was for the befrienders, because they had it in the back of their minds, and some of them said, like, oh, in the last visit, I said it's the last visit, and the person said, what, I wasn't expecting this, but I had said it before, why didn't they remember, they weren't sure whether they managed it right. So the befrienders found difficult the endings more than, which is, again, counterintuitive, than the befriendees. Yeah.
Very good, thank you.
Thank you. Yeah.
One more question up the back, I think, from a clinical psychologist.
Well, you've just answered my second question, because I had 2, and it was about the idea that everybody else says, talks about the cliff edge, and yet for the patients in your trial, they didn't. And I wondered about why that might be, and yeah, just interested that it was the other way around. But I guess I'm wondering about, so when we've done the ICAP, really the carers tell us that they get just as isolated as the people with aphasia, and their social circles really reduce. So I wondered, did you measure them? Would you measure them if you were doing it again? Were they around? Were they in the kitchen with the befriending, or were they out, or did they, if you thought about that at all? We
did measure outcomes with carers. We didn't see any differences there. We looked at carer burden. We thought this may help. They didn't. None of the measures we looked at shifted in any significant way. But going back to your first point, I wanted to say something, and now it's gone. You were talking about, what was your first point? Yes. So one thing I didn't mention is that we didn't recruit. So there was concealment in the recruitment process of consent of recruiting to the trial. So everybody signed up to a trial that looked at outcomes after stroke. So they knew that they were going to be assessed multiple times. That's what we told them. We're just looking at services, different packages of care. We didn't lie, but not the full truth. We would look at different packages of care and compare to see what is better for emotional well-being, but they didn't know what the intervention would be. And then once people consented, there was a second stage consent where we did the randomization. So we ended up with people who said, that's not for me. I don't want anybody coming to my home. So it's not the people. If it was the people who wanted befriending from the start, I think, it would be more likely that it would hit them harder, when it finished. But we had people who didn't want it, and actually meant to say this, and I forgot, that even those that didn't want befriending at the beginning and didn't think it's going to be for them, actually said at the end, we think this should be available to everybody. So this was really powerful as well, because, you know, they wouldn't choose it. I wouldn't choose it, I thought. I thought if I had something and somebody said, I would say no. I'll talk to my friends, I'll go to a support group. I don't want somebody to come, you know, I don't. But actually now I would, obviously, in retrospect, but before I would have said, you know, no, I think my inclination, for no, you know, particular reason. So I think that was really interesting, because it was nice to see that those who didn't think it was for them still thought, actually, this is quite good. Yeah.
Okay, great. Well, we've gone past the magical hour, just about. There's wine, Spanish, and non-alcoholic drinks, and crisps for those who want. So please do stick around. But if we can just thank Katerina one more time.
Thank you.